Okay, so today we're going to discuss about the leukemia, the cytochemistry, and we have also here the lymphoma. So first we have here the leukemia. So leukemia is characterized here by abnormal proliferation of your WBC, characterized here by the presence of your blast cells or your immature cells. Okay, so we have here it's characterized by shift to your left with the presence of your immature cells or your blasts in your peripheral circulation. So the normal myeloid erythroid ratio is 2:1, 4:1, but in your leukemia, it could go as high as 10:1. And then it will also have your normocytic normochromic manifestation of your anemia. Okay, we have here the classification of your leukemia. First, we have here according to the duration. So we have acute, usually manifest here, try to last days to months. Subacute, 2 months to 6 months. For the chronic, try to last here for more than 1 year. According to WBC count, so we have here leukemic leukemia, more than 15,000 with the presence of the blast. Subleukemic leukemia, we have here less than 15,000 with the presence of your blasts. And we have your aleukemic leukemia, on the other hand, would have here less than 15,000 with absence of the blast. And according to the cell type, so we have acute stage. Acute leukemia would most likely be predominance of your acute stages, which are your pro stages, your immature, undifferentiated. But when speak about the chronic one, so it's long-lasting already, longer duration, so expect to have here more differentiated and mature stages would be predominating. Then according to the lineage, so we have here your myeloid and lymphoid. Again, the myeloid includes your proliferation of your myeloid cell lines, which includes here your granulocyte, your monocyte, your RBC, we have also here the platelets, minus your lymphocyte, because the lymphocyte proliferation will be included in your lymphoid type of your leukemia. Okay, then we have here the classification of our leukemia. So we have here the FAB classification. Another one, we have here the World Health Organization. The FAB is your French, American, British classification. The FAB classification is based on the morphology of your cell. This includes here the cell size, the nucleus size, the shape of that, the presence of your nucleoli, and many other considerations, including here your cytochemical staining reactions. It's more of the morphology. But for the World Health Organization classification, it's more of the congenital or chromosomal defects. But our discussion here will be on the FAB classification. We'll not be discussing the World Health Organization. Okay, for the FAB classification, we classify the leukemia here as either lymphocytic or non-lymphocytic leukemia. The non-lymphocytic leukemia, you call that was your that's your granulocytic or even your myelogenous leukemia. Okay, the first discussion, we have here your lymphocytic leukemia. We have your acute lymphocytic leukemia. So again, your acute lymphocytic or your lymphocytic leukemia would always have a negative result in your myeloperoxidase and Sudan black P, which are your cytochemical states. Okay, we have here the ALL, acute lymphocytic leukemia, divided here into your L1, L2, and L3. So in terms of the size, L1 is small, homogeneous, L2 is large, heterogeneous, L3 is large, homogeneous. Cytoplasm here would be scanty or small with the L1, L2 would have your variable, usually moderately abundant, and their L3 would have here moderately abundant. For the shape of the nucleus, L1 would have here regular nucleus shape but would have some clefting or indentation. For the L2 would have irregular with a clefting indentation, and the L3 would have here regular but that one is round or oval. In terms of the vacuolation, so vacuous is very prominent in the L3. And for the nuclei, so small here for the L1, L2 would have one or more, or often large. And for the L3 would have here one or more present for the nuclei, and that one would often very prominent. Okay, your L1 is your childhood ALL. So that's for the age, if the patient is children or child here. So L1, L2 is occurring on the old age population, making this one your adult ALL, and L3 associated with your Burkitt lymphoma. Then we have also here for WBC count. So your L1 would have here less than 20,000 WBC count. For the L2 would have here more than 20,000. And for the L3, would have your almost normal to slightly increased WBC count. For the cytochemical stain, periodic acid shift or PASI will give a positive result only for the L1 and L2. And for your oil red O here would be positive only for your L3. Okay, now we have here the phenotypic typing here of your ALL. So we have your early B ALL, also called here the progenitor, also here the pre B ALL. It's characterized here with the following CD markers: CD3419, CD22, and we have your terminal deoxynucleotide transferase. Your intermediate BAL characterized by the presence of CD34, CD19, CD22, and your CD10 plus your TDT. And your precursor BALL characterized by the presence of your CD34, CD19, CD22, and cytoplasmic mu marker plus the TDT. And your TALL characterized by the presence of CD2, 3, 4, 5, 7, and 8, and the presence of your TDT or your terminal deoxynucleotide transferase. Chronic lymphocytic leukemia, on the other hand, we always have the lymphadenopathy. Basta it involves here, that one is lymphocytic leukemia. Expect the patient to have a lymphadenopathy or the inflammation of the lymph nodes. And we have here the right classification for your CLL, but we will not be discussing that one. Okay, now we go to your AML or your ANLL, your acute non-lymphocytic leukemia. Other name for that is your acute myelogenous leukemia or acute granulocytic leukemia. Again, our rule here for the cytochemical staining reaction for your ANLL, AML, so it will give a positive result for your Sudan Black B and your myeloperoxidase. That would help then differentiate that one with your ALL, where in the ALL is negative for both your myeloperoxidase and Sudan Black B. So acute leukemia is characterized here by the presence of more than 30% blasts in the peripheral circulation. Okay, we have here the M0. So they are designated here M0 to M7. Okay, so M0 is your acute myelogenous leukemia or acute undifferentiated leukemia, characterized here by the presence more than 30% of blasts. M1 is acute myelogenous leukemia without maturation or differentiation, characterized by more than 30% blasts and less than 10% granulocytic cells. Your M2 is acute myelogenous leukemia with maturation differentiation, characterized here by more than 30% of blasts and more than 10% granulocytic cells. M3 is your AML, acute APL, acute promyelocytic leukemia. So this is characterized here by more than 30% blasts and more than 50% are your promyelocytes. So this is also characterized here by the presence of your phagocytic cells or the bundles of your aurorites that's in your M3. And it's also associated here with high incidence of your DIC or disseminated intravascular coagulopathy. Okay, then we have here the classification of your M3. So we have here the hypergranular, and we have also here the micro hyper, and we have the hypogranular. Hypergranular is your macrogranular, so variant is characterized here by high concentration of the granules and large and numerous granules. Also characterized here by leukocytosis, so increased WBC count. The variant hypogranular, the microgranular, characterized here by smaller granules and less number of the granules. And that's also heavier characterized by leukopenia. M4 is acute myelomonocytic leukemia, characterized by the presence of 20 to 80% of your monocytic cells. This is your Nigeli type. Then M4E is your with eosinophilia, the variant of that, and characterized by the presence of more than 3% eosinophils in the bone marrow of the patients. M5A is acute monocytic leukemia without maturation or without differentiation, characterized by more than 80% monocytic cells and more than 80% are monoblasts. It's also called here Schilling's type. M5B is your acute monocytic leukemia with maturation differentiation, characterized by more than 80% monocytic cells and more than 80% are your monoblasts. M6 is your erythroleukemia, characterized here by more than 30% blasts and more than 50% are erythroblasts. It is characterized here by past positive or your periodic acid shift positive. Other name for that is your Guglielmo anemia. M7 is your acute megakaryocytic leukemia, so characterized by more than 30% blasts and more than 30% are megakaryoblast. Okay, the next one, we have here your myelodysplastic syndrome. So myelodysplastic syndrome is considered to be a pre-leukemic syndrome characterized here by less than 30% blasts. If left untreated, it could progress to become your acute leukemia. Remember that your acute leukemia would always have here more than 30% blasts. So myelodysplastic pag less than 30% blasts. Classification of that is based on the percentage of the blasts here found in your peripheral blood and even in your bone marrow. So first one, RA, refractory anemia, so less than 1% peripheral blood and less than 5% of your blasts in your bone marrow. Then refractory anemia with your ring sideroblasts, so that would have your same percentage, only that would have your majority of that 50% would have here the presence of your ring sideroblasts. The next one, we have the refractory anemia with excessive blasts. So this one less than 5%, less than 5 to 20% in your bone marrow. Refractory anemia with excessive blast transformation. So more than 5% blasts are found in your peripheral blood, and we have here 20-30% blasts found here in your bone marrow. And chronic myelogenous, chronic myelomonocytic leukemia, characterized here by less than 5% blasts in peripheral blood and a present 5 to 20% blasts found in your bone marrow with a predominance of your monocytic cells. Another type of leukemia, we have here your myeloproliferative syndrome. Myeloproliferative syndrome here characterized by abnormal proliferation of your myeloid cell lines. So this includes here your, again, myeloid cell lines, includes here the lines including your RBC, your platelets, your granulocytes, but not your lymphocytes. For the first one, we have the CML, chronic myelogenous leukemia, characterized by the presence of your Philadelphia chromosome. So Philadelphia chromosome involves here the translocation of the short arm of your chromosome number 2, lumipat siya sa long arm of your chromosome number 9, and that would give your characteristics na extra short chromosome number 22 and extra long na chromosome number 9. So chromosome number 22 is your BCR gene, and your chromosome number 9 is your ABL. So Philadelphia chromosome is the combination of your BCR ABL gene. Another one, we have here the MMM, myelofibrosis with your myeloid metaplasia, characterized by the predominance of your duct cryocyte or your teardrops. Essential thrombocythemia would affect here or problem related to your platelets. And polycythemia vera, on the other hand, would have here problem related to your almost all of your blood cells. So that would be related to your RBC then. So increase RBC, platelets, WBC, characterized here as panmyelocytosis or pancytosis in your peripheral blood smear. Okay, the next one, we have here the leukemoid reaction. So leukemoid reaction would have here the blood picture that may resemble your leukemia. It might be also have the presence of your immature cells. But then again, if you try to check your blood-forming organs, there's no defects on that. So it would have here resemble your leukemia because it would have here as high as more than 50,000 WBC count. So you might suspect for the leukemia, but actually it's not a leukemia. Leukemoid reaction may be secondary here to some infections like mga bacterial infections that might result here to like sepsis. It might eventually result here to very high WBC count. Okay, so we have here the differentiation between your leukemoid reaction versus your CML. So first one, in the leukemoid reaction, what's being increased here is only the neutrophil. But in the CML, what's being increased includes your neutrophil, eosinophil, and your basophil. In terms of the platelet size, morphology, and the number, your leukemoid reaction will have normal. For the CML, would have here abnormal morphology and even abnormal form of your platelets. The lab score, leukocyte alkaline phosphatase, would also help here differentiate between the two. Again, leukemoid reaction characterized by an increase in your lab score, whereas your CML would have here a decrease in your lab score. Talking about your labs, so you have your leukocyte alkaline phosphatase. So the method for that is your Kaplos method. Leukocyte alkaline phosphatase is usually found here on the secondary granules of your neutrophils. Okay, and okay, the normal values for that is 20 to 100. Okay, the specimen used here would be the blood coming from your skin puncture, capillary blood, more than the blood coming from the ETA, because the ETA contains enzyme that might be inhibitory to your reactions. Then you try to stain, and then the result here should have your brown, black precipitate. And then you try to grade according to the intensity of the staining reaction. So you're going to count 100 neutrophil. What you're going to evaluate here includes only your band and your segmental neutrophil, and try to evaluate based on the intensity of reaction as 0 to 4. Then out of the 100, okay, so every cell you try to give a score, and then try to multiply with a score, and then you total that 1. That become here like cell number 1, intensity is 1, so that's 1. Cell number 2, intensity of that is 4, so that's 4. And then you add the total entire, and add here the total, and the entire lab score would be recorded. Okay, normal values for that, we have 20 to 100. Okay, for here, we have that decreased lab score, mean to say less than 20, could be associated here with the following conditions. So we have your CML, we have your sideroblastic anemia. You could also have here the PNH, paroxysmal nocturnal hemoglobinuria, and we have also your myelodysplastic syndrome. Increased lab score, more than 100 score, would be related to your Leukemoid reaction, to your polycythemia vera, third try pregnancy, or even infection and intoxication.